This meeting is being live streamed. It's starting now. I don't know if we can delay it.
Good day and welcome everybody. We are online. Can we just give everybody 5 more minutes before we start? And we'll take it from there. Thank you for your patience. Good day, everybody. It gives me an immense pleasure to extend a very warm welcome to our guest speaker, competitors, the student participants, the EXCO, and some extra people who are attending. And I very warmly welcome my dean, who's on the session, to the South African Division of the International Association of the IADR competition session, hosted by all dental schools, faculties in South Africa, UWC, University of Pretoria, SMU, WITS, and UKZN. Why only competitions, you may ask? According to the constitution of the IADR and the AMIR group, to which South Africa IADR SA subscribes to as a member, in the year the IADR AMIR hosts a meeting, a regional meeting, no local meeting can be held. And so to encourage everyone from the different divisions to attend that regional meeting, we've decided not to have local meetings. But because the Hatton competitions occur annually, we do not want to disadvantage our students and make them lose such a good opportunity to share their research at such a prestigious session. That's why we're only hosting the competition, so that we can send a winner to the session that will be held in 2023. And I'll speak a little bit about that a little later. As we continue with our busy academic schedules and as we slowly return to the pre-pandemic settings, when I say pre-pandemic, and we can never really entirely return to that, I just mean more face-to-face classes, meetings, conferences, and travels. But still very much aware of the pandemic and its ravaging effects, its impact had on our lives, on the lives of millions. We appeal to every day. We appeal to you to remain safe and alert. We are still the ones at the greatest risk of contracting this virus, dentistry, and being in this dental environment, and we should not slack in terms of protocols that were instituted for our safety at all our different institutions. We know the world of research is also returning to pre-pandemic times, but being exposed to pandemic conditions allowed us to rethink how we conduct research. And I encourage all researchers to be cognizant of some of these ideas and ideals and continue with that changed and open mindset. Some new trends have been set, which allowed us to rethink what we research, what we teach, and what is appropriate for the different settings, and all this using an evidence-based approach with greater rigor and care. And this should continue. We have seen the differences across nations, whether it's the stark differences between the rich and the poor, and between Africa and the rest of the world, especially when it came to vaccines and its development and especially its distribution. As Africa, we learned that we need to take care of ourselves. Thus, our theme, Africa Today, driving dental research beyond COVID-19. When we think about, that was the whole idea behind choosing that kind of theme for today. We were forced to transform our institutions and faculties and our research agendas to address issues impacting us as Africa. Research must be aligned to our communities and our patients' needs, and to this end, change our policies for us, but also addressing the Sustainable Development Goals set for 2030 and even the WHO terms of references for Africa must become a focus amongst our researchers. These were developed with us in mind, and we should not allow people who do not understand our communities, our circumstances, our people to take the lead. If anything, I think COVID taught us that. The goal of IDR SA has always been and remains to provide an approachable and encouraging research platform for novel and experienced academics and researchers in the field of oral health and oral health education. COVID has also taught us that we can be even more innovative and has made the world a smaller place where meetings are held as hybrid events, allowing many more people to partake and share research and their expertise. My sincere thanks to the guest speaker who graciously accepted our invitation, to the deans of the SA Dental Schools, the competitors and attendees, and finally our sponsors for their financial contributions for this event to make it a success. It was truly also my privilege and my honor to lead this dental research organization and end my tenure as president of the SAIDR. So my heartfelt thanks to my colleagues and members of the executive committee, including the past presidents who provided support and encouragement. I wish all the competitors of research well with today's proceedings. And lastly, just to share with you, the IADR Amir Group meeting will be held in December from the 8th to the 10th of December in Riyadh, Saudi Arabia, and it will be a hybrid meeting. So please feel free to join and encourage your students to join. Abstract submission deadline is the 30th of September, 2022. And the next general session of the IADR will be held in Colombia in 2023. So please go to the website and join IADR and also send abstracts to join those meetings. I call upon Professor Chetty to introduce our guest speaker.
I was almost going to say my video wasn't working. So today, good afternoon, everybody. Our keynote speaker for today is Professor Henry Adeola. I'm sure many of you know him already. He's going to give us a talk entitled The Basic Principles of Translational, and clinical dental research. He has an impressive bio, which I'm going to read to you. Professor Adeola received his PhD in cancer proteomics and genomics at the University of Cape Town through a grant called the International Center for Genetic Engineering and Biotechnology Fellowship. He is certified in clinical research from Harvard Medical School. He was a visiting scholar at the Niigata University Medical and Dental Hospital in Japan, where he studied the molecular pathoepidemiology and genomics of oropharyngeal head and neck cancers. In addition, Prof. Adeola has significantly contributed to the establishment of a research laboratory and provides academic, administrative, and research leadership at the Division of Dermatology Head and Skin Research Lab at UCT. He has been appointed to Associate Professor in the Division of Dermatology. And in terms of his publications, he has published over 60 peer-reviewed papers and book chapters. He is an NRF-rated scientist, principal investigator of several grants and projects involving local and international agencies. Finally, the caliber of his teaching, research, service rendering, and educational activities and social responsiveness has resulted in several prestigious international awards, both within and outside the African continent. So, Professor Adeola, we are honored to have you with us today, and I now hand over to you.
Thank you very much, Professor Manogri Chetty. I'm most grateful to you and also to your team, Prof. Sadika Khan and all the brilliant people on your team. I consider it a great honor to be invited to have a quick chat with our colleagues regarding clinical and translational research. So let me just put up my slide while I continue to talk. Are you able to see my slide right now?
We can see your slide. Perhaps you want to put it on slideshow.
Okay, just a second. Okay, let me stop share and reshare. How about now? Can you see it now?
Yes, we can.
Okay.
I'm just.
But I'll put it on slideshow. I just wanted to be sure that you can see it.
Yes, we can see.
Okay, all right. So thank you so much for this. Today, I will present to you an introductory discussion on clinical and translational dental research. I will be aiming to provide you with some of the fundamental information that are critical to the improvement of your skills in clinical oral health research and effective ways to remain updated in best practice in clinical dental care. So about a month ago, I was ambushed by my daughter, the youngest of my kids. And she asked me and said, why do we say God bless you when people sneeze? And of course, I'm big old daddy. I couldn't pretend not to know why. I mean, after all, I've been here for so long. So I tried to change the topic, dribble her, but she was insistent on knowing, you know, the reason why you say God bless you. And with a bit of defeat, I finally agreed that I actually do not know. And please don't laugh at me. I'm sure many of you also do not know why people say God bless you. So I considered it a task that I had to take her into Uncle Professor Google's archives and to see. And I actually realized that it was one of the prayers that the Pope suggested that be offered to people who had the plague, you know, during the severe plague. And I realized something very key in that moment, that we always assume we know things until we find out that we really do not know. So I think the meeting today is a good opportunity to set some very, very good foundation for the graduate students and undergraduate students, if there are any here, to understand some of the key concepts in clinical dental research, so that we can talk about all these electrons and protons that we are finding without even understanding what the basic backbone of dental research should be. So I've set some objectives which I am hoping I will achieve in the very little time. I tend to be very talkative, so I'm going to set my time to know if I'm flying over the time set for me. So some of the learning objectives I'm hoping that we would cover today is for you just to have a general basic understanding of clinical research. I also hope that you would understand some very, very basic concepts in translational research. And also, what are the types of evidences? What sort of evidences do we have? And be able to formulate research questions. So today we are going to learn how to craft good research questions and what is the anatomy of hypothesis in research. So I've chosen to use this outline. So please just ignore the last bullet in this outline. I'm not going to be able to reach that point before my time is up. So I'll start with a quote from Albert Einstein that says that if we know what we are doing, it wouldn't be called research, would it? So I'm going to dive now into the key processes that are important for research. The first one is to identify what the general problem or question is. And then we set out to do a very, very thorough literature review. You want to know, you don't want to reinvent the wheel. Why do you want to spend 6 months, 1 year on doing a system or doing a research or a study, and in the end you find out it's already done? So sometimes it's a waste of time to not do literature research and just dive into your program. The next thing is to specify your question, so hypothesis, and then determine how to design your method. Once that is out of the way, then you set out to collect data. You collect data, you prepare data, you kind of curate the data very carefully and make sure that you are only retaining parts of that data that is necessary for you to answer essentially your question. And then you put this data together and analyze and plan to present. And your presentation can be in form of what I'm doing right now, or can be you in Las Vegas presenting your work. And then you also have to kind of give meaning to what you have ultimately found. So what is clinical research? So clinical research basically is a research in which people or data or sample of tissue from people are studied to understand health and disease. And what does this do? It helps to find new and better ways to detect, diagnose, treat, and to prevent disease. So now you can have different types of clinical research, including clinical trials, which test new treatment for a disease. And then you have natural history studies, which collect health information to understand how a disease develops and how does it progress over time. So we can apply clinical research to a range of health fields for clinical practice. And these fields are not only limited to this, but these are some key areas in which you can apply clinical research, ranging from epidemiology to biostats to health policy, to AI, to decision science, and even as far as behavioral science, biology, chemistry, pathology, anatomy, and all sorts of studies that involve human factor. So how do we define clinical research? The key part that we must take home from this talk is the fact that there is always a human component to it. And so it does not involve the study of rats or pigs or dogs. So clinical research is the core, the anchor is that it typically involves humans or information that is gathered or collected from humans. So now that that is well established, I think it's very important for us to understand what translational research is. I know that many of us use the word translational research quite loosely. We want our work to be translational. We want our work to be translational. But what exactly is translational research? So basically, it's a transformation process. So basically, the research that you do is being converted from laboratory practice to what is of clinical utility. So that is very, very important to kind of understand what that is. And this definition is from the NCATs. So I put here some of the key domains of clinical translational research, which includes areas from public health to basic research, to preclinical research, to clinical research, and to the implementation of all of this. But as you see in that wheel, the center is always typically patient involvement. And we should understand that it is a non-linear process. So it's not only taking information from the lab or from the chair or from the bench to the bedside. It is also making observations from the bedside that can inform what you do on the bench. So there are incremental building stages to this research. And as we said, there is the key part of it is patient involvement. And there are different levels of clinical research, translational research, ranging from T0 to T4. And of course, you can see in this picture the components or the content of each different stage. And you can see that there is an overlap in knowledge exchange between community information and the information that the academics generate. Sorry, this keeps coming up. So, of course, I'm sure most of us know now the different pathways in which prevention can be achieved. Of course, you have starting from your primary prevention, where you can go to swim or go to jog or run. to early detection, early treatment, which of course is the secondary prevention, like screening for lumps in the breast. And ultimately, beyond that, when the individual is critically ill, they have to finally find themselves in the hospital. So here we have a picture that shows the structure of the clinical trial or your translational research. So natural history studies are extremely important. So natural history studies look at what disease looks like over time. You are interested in information like how does disease change? And then you want to know if there are markers that predict whether a disease will improve or worsen, and what are the specific biomarkers or indicators of the disease, and who ultimately is the patient population. So now let's look at the workflow on how you kind of engage with clinical research to give you a useful outcome in the end. So the most important foundational concept of clinical research is to be able to ask and craft a good clinical question. Once that is out of the way, you want to gather data. So data is very important, and I've shown you all sorts of things, even things we're not aware of, from which we can generate data. One interesting data, for example, that you can generate at your dental school is to put a roster in front of the entrance of your dental school and take the time that people clock in every morning. And then you would be able to find trends. Who are the latecomers? Who are the regular? Who are the early birds? So there's a lot of places where data can be generated for the question that you're asking. You don't get your data and then think of what question to ask. Your questions usually lead you to ask which type of data that you want to use to answer that question. And of course, it's very important for you to have the appropriate skill set. If you have all of this, if you have very good skill in all of these three domains, then there is no doubt that you would end up with lots and lots of very, very decent impact factor publications. So how do we develop our question? We need to start with a clear purpose. You have to be familiar with your literature, as I already mentioned. You have to go through an iterative process. You keep checking to make sure you're not leaving anything out, so that when people see your work, they would know that it has been well and carefully thought out. And then you try to specify who, what, where, and when of your purpose. And then you ask yourself, what would be the answer to this question? What would that question add to the literature? So also, you should not be one who allow methodology to drive your research. So the fact that you have a state-of-the-art mass spectrometer or you have a laser capture microdissection system does not mean that all of your research must include that tool. So you have to ask yourself, what are the best tools to answer the question that I'm asking? So the next thing I'm going to talk to you about, which is something that is always very interesting in the field of clinical research, is causality. So when things seem to be occurring at the same time, happening together, can we prove that these things are related in a causal pathway? So does A, exposure, lead to B, outcome? So an example is, you can say that people with advanced periodontitis have higher risk of heart attack. What are the potential explanations? How can you explain such an observation? So that observation can be completely random, has nothing to do with a link of any sort. The observation may have been arrived at based on a bias in your selection or in how you are measuring your outcome. Then there can be confounding factors. Of course, confounding factors are typically unexplained heterogeneity in the data that you are observing. Maybe you are looking at only a clinic that is in the bush, in the outskirts, and there's a lot of elderly people there. And if you keep seeing advanced periodontitis, age in that instance is a confounder. And of course, the one that we want there to be a true causal relationship. So a very clever guy called Bradford Hill created some a list. Of course, you can look at it for yourself. I don't have much time to go through this now. So some criteria have been set forth by Bradford Hill, which is known as the Bradford Hill's criteria, which talks about what has to exist before you can say there is truly a causal relationship. So finding a strength of association using risk ratios or odds ratio does not automatically confirm that a condition is being caused by a particular type of exposure. And the list goes on and on and on. Of course, you can look at this up by yourself on the internet. It's everywhere, so there's no need to. But there are certain key criteria that have to exist before we can establish causality. So let's look at the characteristics of your research question, because of course, from the nomogram that I presented to you, you can see that you go from your question to your data, and then your analysis, your skill set, and ultimately your analysis. So I'm going to put an acronym for you, which I hope that you will all remember in terms of how you carry out research. It is called FINER, F-I-N-E-R. F stands for feasibility. I stands for interesting to the investigator. N stands for novel, E stands for ethical, and R stands for relevant. So if we come to the F, which is the criteria for feasibility, we need to be sure that there is adequate number of subjects, adequate technical expertise, affordable in time and money. So for example, if you're doing a master's degree or a PhD, you can't select a project that will take you 15 years to complete, right? So that is going to waste your time. And also, why do a project that can be done with 5,000 Rand with 500,000 Rand, and you will get exactly the same result? So, and then it must be manageable in scope. You can't say you want to test the bilirubin level of everybody in South Africa, Botswana, and Tunisia. It's a waste of time. So you have to have a manageable area that you are interested in working on. So let's look at interest. So the interest is something that you are passionate about. Something that you want to be passionate about. Something that you want to be an expert in, right? Something that makes a difference in the world. You know, it's just like counting how many segments that does the last hair strand on the leg of an insect have. Well, it's ultimately it's going to provide some information, but in the grand scheme of things, it does not. It's not the most important problem that the world is facing. So let's look at novel. What we mean about your research being novel is that it either confirms or refutes previous findings. It should extend previous findings if it does not confirm or refute it. Then you have to be able to provide new finding from your work. What are the criteria for ethical? We are almost at the end of our final. It has to have respect for human beings. There has to be non-maleficence and beneficence. That means the risk of your work must not outweigh or overshadow the benefit of your work. So there's also respect for confidentiality. And there's also respect for informed consent. And let me tell you what that means. Most people always say we took consent, we took consent. You see, the word informed consent is not by accident. The informed part is the most important part of an informed consent because you have to provide information. If you are going to cut my little finger, I need to know that that's exactly what you are doing. Or if you are going to do a procedure, then you tell the patient, oh no, what you are feeling is just pressure. It's not pain, it's not really pain. You know, so we have to make sure that the patient knows what magnitude of discomfort are they going to experience. And then finally, as I had said, there has to be beneficence and non-maleficence, and it has to be socially justifiable. And the reason why all these rules were brought forth is because of some of the very bad practices that are being carried out with things like the syphilis study in the US and so many other studies all around the world. So finally, relevance. It has to be relevant to scientific knowledge. It has to be relevant to clinical and public health or health policy. It has to be relevant to future research direction. It has to be pivotal in terms of how are we now going to start looking at that area of your question. So let me show you some spurious results that people have got and they think there is a correlation. So some study is looking at people who drowned after falling out of a fishbone boat and marriage rates in Kentucky. Do you believe that is possible? Can you say that people falling out of a fish boat is responsible for lowering the rates of marriage in Kentucky? Another one, consumption of cheese is correlating with the total revenue generated by golf courses. I mean, what is the link? But look at the graph, how beautifully correlated it looks. So the fact that things are correlated does not mean they are causal or have a strong association. So now that you understand some of these basic concepts, let's look at building your research questions. What are the bolts and nuts of building research questions? The parts that I've highlighted in red are the key components of your research question. You have to define a population, right, that you are looking at. And then you have to define what exposure are this population being given, and then how associated is that with an outcome. Okay, I need to fly now. I see, I told you already that I tend to get carried away. So now these are the three components: population, your exposure, and association in terms of outcome. So now let's bring that to earth and talk about real people. In a population, so this is an exemplar of a well-crafted research question. Our population here are pensioners. We are specific. It's not just everybody. Pensioners over 60. So the age is also fixed. And where are they? They are at Tigerberg Hospital. And the exposure, advanced periodontitis, and the outcome is an increased risk of heart attack. So now we are going to look at how we will put that in an hypothesis format. So in a population of that, advanced periodontitis is associated with higher risk of heart attack. So I need to make it clear at this point that there is a difference between your research hypothesis and your statistical hypothesis. Statistics is applied to research to eliminate the role of chance in your finding. So your statistical hypotheses are a different class of hypothesis. Your hypothesis is your, let me use it in modern language, your gut feeling. You know, what you think is happening from your observation. But your statistical hypothesis has to be crafted to disprove or validate your hunch or gut feeling. So this is how you set out your null hypothesis. You are saying that there is no association between the two variables, the outcome and the exposure variable. And then you set other hypotheses, which can be, it's not only one, there can be 10 alternate hypotheses. And the alternate hypothesis would say there is association. There is risk of increase. There is risk of decrease. There is risk of no change. So different type of alternative hypotheses exist. So why did we not say advanced periodontitis is associated with higher risk of heart attack? We could have said that. We could have said advanced periodontitis is associated with higher risk of heart attack. Clever Karl Popper. He says, we can't conclusively prove a hypothesis, but we can conclusively disprove one. So we cannot say higher because we don't know in which direction the outcome will be, unless we already know. So it's always better to talk about it affecting the change, but not specifying in which direction, unless that is the only outcome that you're interested in. So I put in this slide at the last minute. Is the OCD in me that's working like that. I'm not going to be able to make too much discussion around it. But I didn't think my talk would be complete without mentioning to you that statistical power is absolutely important in research. In fact, a poorly powered study is a waste of money and resources. I mean, you might as well just go to the beach, lie down and sip on pina colada. There's no point doing studies, wasting 150,000 rand, using 15 patients. You needed 27. In the end, the power of your study is only 40%. The statistical power, which is 1 minus beta, which is your beta error, has been set at 0.8. And if you, the higher, the better. So just bear that in mind for your study. If people say, make sure your study is well powered, they are not just trying to be a pin in the neck, right? It is extremely important that you have that. So in definition, power is the probability of rejecting the null hypothesis, which in fact it is false, right? So if the null hypothesis is false, your power should be able to pick that up. And of course, I hope you know that your alpha, the alpha error is your false positives, and your beta errors are your false negatives. Okay, so we're finally there. I think I've not done too badly with time. Of course, the organizers will let me know when I'm done. So I'm trying to summarize and make some reflection in terms of what are the clinical, the important things that we need to know about our work. Clinical research always involves research activity that are human-oriented. Translational research involves converting research from bench to bedside and to communities or to population. When you carry out good clinical research, you have to be fair in your comparison of groups. You have to be fair in your comparison of groups. If you wanted to compare men and women who can run, you cannot put tall, long-legged men with short, tiny-legged women. You have to make sure that the two groups are balanced. They look physically the same. They look they look exactly the same height, the same build, possibly the same weight, possibly the same heart rate. You know, you have to make sure that you match your groups in a way that one group is not unduly advantaged over the other. The role of chance, which of course you interrogate using your statistical approaches. The role of confounders and bias should be considered before declaring spuriously an association between an exposure and an outcome. And I would leave you on this note that a study is only as good as the design of that study. And I would like to thank the Harvard Medical School for the materials that have been used to train us in clinical research. These were quite useful to present this talk to you. Thank you all.
Thank you, Prof. That was an enjoyable talk. Would you mind if I opened the floor to any questions or discussions that anyone would perhaps engage with? All right, so anybody, if you have any questions, you're welcome to raise your hand and unmute. Shenuka?
Thank you, Prof, for a very interesting presentation and for providing a detailed breakdown in terms of the study methodologies and the approaches to be used in clinical research. So one of the challenges facing researchers is the dual role of that they play, particularly as clinicians as well as researchers. Now, the goals of clinical management are very much different from research goals. And likewise, the ethical considerations for clinical care as well as clinical research would be different. So how can we improve understanding of these different roles, and what would be the implications for both research ethics as well as for research integrity? Because both of these are going to lead into the validity as well as the reliability of clinical research in general. I'd like to hear your views on this. Thank you.
So thanks so much, Sheruka. Thank you very much for your question. And it's very interesting that you asked that question because this is one of the ideologies that are very close to my heart. You know, I'm a strong fanatic for dental or dentist scientists in Africa. Because one of the major issues is your workload as a clinician. So the workload of clinicians is understandably a lot, you know, in which kind of creates a scenario where there is no interest, not a lot of interest in research. And so I think the starting point or the foundation for having very good exposure to clinical research as well as to ethical guidelines for performing clinical research. So I don't believe there are two different rules for different researches. I actually think it's just one broad rule. In fact, the rule we are discussing here are applicable to mathematics, to physics, to geology, to archaeology, to language, any sorts of field of endeavor. The basic foundational concepts are the same. I hope that helps a bit.
Thank you, Prof. Is there anybody else would like to say anything? Or perhaps
May I?
Prof. Kanya, go ahead.
Thank you, Professor Adeola,
Thank you so
for
much.
this conversation on translational research. You know, we have this conversation in my faculty all the time, and you're perfectly right when you say people use the word translational research very loosely. And so much so that we as a group in my department, we've actually decided we're going to speak about translational research next week in one of our lunchtime sessions. It's going to be, we were trying to see how we were going to approach the subject, and we said we're going to demystify the subject of translational research. So people use it very, very loosely, and it's an area that's very close to my heart. Maybe if you can enlighten us a little bit about facilitators and barriers to this type of translational research. Do you have any that you can share with us?
Yes. So the center of opportunities that can be leveraged in translational research is for clinicians to be able to have access to protected time. So I always say this. I left my whole very comfortable clinical practice and I went to do a PhD. And I think one day I'm going to invite a conference to explain what happened in my journey of PhD. But I just realized that there's a lot out there that we are, it's the deep end basically. So one would have to unlearn certain ways to be able to embrace some of these emerging molecular approaches, which of course they are kind of coming back to make the life of clinicians a lot easier. So my first part in terms of how do we start to now change the landscape to kind of enlighten clinicians more about translational research is the willingness to launch out into the unknown, and also the willingness to have protected time. You have to be willing. It's either the hospital is happy to let you go 20% of your time or 30% of your time so that you can do some meaningful research, right? Or you as the individual are willing to forego a bit of comfort to have exposure to the necessary tools. Because like you said, people, or I also used to say that, I mean, it's very fancy to say translational research. You know, once you say that, it's like you're translating something. But translational research includes the understanding of the clinicians of the processes that are involved in research, you know, and not just, you know, I supervise students, particularly clinical students, and every time it comes to stats, I don't, it's almost as if something scary has come. You know, it's like I will go to the biostat, we'll go to statistician. There are some basic stats that it's very funny to say that you need to get a statistician to do bar graphs for you, you know, or even something as simple as a t-test, you know. So the interest has to be there, because when we know better, we will do better. So I think that the key part is to be fearless, to be bold, to have courage, and to be able to say, you know what, I want to be part of this translational research, and what does it ask of me, and how am I willing to give what it asks of me?
Thank you, Prof. Rajeshri, I see your hand is up.
Yes. Hello, everybody. And thank you, Prof, for that interesting lecture. Stemming from Shenuka's question, the whole idea of translational research is the translational pipeline, so the development of research and interventions. So, Prof, can you comment on the vaccine, the COVID vaccine, the development? I can't resist but ask this question.
You're throwing me under the bus there. I'm an ideologue of all sorts of line of thinking about the vaccines. Okay, so okay, maybe you can be more specific.
I don't need a detailed answer, just a comment of your thoughts.
Okay, so I'll put it this way. The vaccines are the way to go in the future for the protection of disease amongst human populations. And one issue that is beginning to become very clear is that there is climate change, right? Weather is really bad, and it's causing a lot of problems everywhere. It's not only affecting humans, it's also affecting animals. You know, they are dying, they are getting infected, and humans are interfering a lot with the genome of viruses and of bacteria and of different sorts of organisms. So the way forward, in my opinion, is for everyone to embrace what I call one science, one health, right? Instead of having this silo of dentists, physiotherapists, pharmacologists, no, it's one health. And under the umbrella of one health, animal health is very important. Environmental health is very important, and human health is very important. And all these three, the environment, the health of the environment, and the health of the other inhabitants of the environment, which are, of course, the animals, and in the environment, there is the flora, the plants, and then the humans. So we have to always have that integrated approach in the center. And this is why I say that the vaccine is the way of the future, it's the way to go, because we have to be able to have a multi-scale, multi-dimensional look at our whole world and design smart technologies that is going to accelerate our health, and particularly oral health, of course, which is my own field of interest.
Thank you. If there's no other questions, Prof, can I just maybe ask for your opinion on something? You suggested that, yes, we are, from the dental fraternity, we have lots of obligations. So one of them being clinical, one of them being teaching and learning. And you probably would have noticed that in most developing countries, once they finished an undergrad degree, they would go on to try and specialize in the clinical disciplines. Now, do you not, what are your thoughts? Are we not losing, it's kind of like a brain drain to research? Do you have any thoughts on how we might be able to overcome that in a resource-challenged country, environment, for example, just in Africa?
So if I understand your comments correctly, you're saying that dental trainees go and do another field of study.
No, what I'm saying is that when they do choose, for example, to do any postgrad work, tends to always be in a clinical discipline, which obviously are more lucrative. So moving into an area of research, it's not as lucrative as these clinical areas. How would one even think of overcoming these kind of issues in a resource-challenged country? I mean, what would be put in place?
Yeah, so thanks so much for that. That is a very, very beautiful question. And it's one of the areas I'm also very passionate about, which is the dentist scientist training. So there are no incentives at the moment for people who are passionate about science research or who would like to explore the opportunities that exist in other fields for applied application to the field of dentistry. And we need a lot of that. And a lot of that is happening in medicine, which unfortunately is not happening in dentistry. And there is no other workforce apart from us. And I've always said to my friends that when you say dental, or dentist, most people automatically think of scaling and polishing. They only think about cleaning teeth, whitening teeth to be more beautiful, which of course is very important. But they forget that the teeth are not standing inside a rock in the mouth. The teeth are standing inside bone, and there is tissues around it. And the knowledge, the science that applies to the tissues in the liver or in the prostate is still very relevant and largely unexplored in the oral cavity. So I kind of love the word oral health, because it just shows everything in the oral region, including your teeth, your tissues, your tonsils, your lymph nodes, everything is dental, right? So it's still a huge gap on the African continent. And I'm very, very grateful to you for bringing that up, Prof. Chetty. It's very, very important to understand that there is it's like that scripture that says the harvest is plenteous, but the laborers are few. There's a lot that can be leveraged and opportunities that need to be taken and that must be taken. But there are very few people. But it's very, think about it. It's so hard to not be practicing as a dentist. How much are you going to be collecting? So nobody, when we consider how many mouths we need to feed and how a lot has been invested in us. You don't want to go and, you know, not make money. But at the same time, you have to have a goal that transcends only your own comfort. You have to think about how is it that one can contribute in a meaningful or palpable way to developing dentistry in Africa.
Yes, I actually agree with that, because if you look at evidence-based dentistry, the only way it can grow is with research. But I think this might be an ideal platform for me to just put out there. So within South Africa, for example, the SAMRC has quite a few funds available. And Prof. Yengopal and I attended a workshop. And the one thing that they mentioned was that in the entire country, there was only one applicant from a dental school that applied for the clinician scientist fellowship. And they were inviting, you know, they were wanting to invite more applications. So perhaps this is something that everyone can take back to their universities, because there are funds available to do research as well. If there aren't any more questions, then Prof, we thank you very much for your time.
Thanks for having me.
And take care then.
All right. Bye.
Bye-bye.
Thank you, Professor Adeola. I just wanted to say thank you for your time.
It's a pleasure.
Right. I think now we're at the next stage. We would now move on to the IADR competitions in the postgrad division. Our first student that will be doing her presentation is Huda. She is from the Department of Radiology at UWC, and her topic is prevalence and location of the MB2 in the maxillary first and second molars using CBCT in a sample of Libyan population. Now, for those of you that don't know what MB2 was, and I must admit I was one of them, it's the secondary mesiobuccal canal in maxillary molars. So Huda, you can start to share your screen and take us through your presentation. Okay, are you there? Are you struggling to get online, or? Maybe put something in the chat so that we know where you are and what you're doing.
Prof. Shetty, can you hear me?
I can.
There is no any choices that which can share my screen here. I don't know why.
Rajeshri, maybe one would need to enable her to share.
So can you see here my screen?
I'm going to check.
Can you see my screen?
No, we can't see your screen.
I can't see your presentation.
Shanuka, can you help her out?
It looks like something is muted, or I don't know why. Yeah.
Okay, Prof.
Please indicate to me when you want me to turn your slides to move. Thank you.
Okay. Okay, so can you hear me, please?
We can.
Okay, so good afternoon, everyone. I am Huda Mohammed Abu Ghaiba. I would like to present the prevalence and location of MB2 in maxillary first and second permanent molars using COMPIM CT in a sample of Libyan population. Yeah. So can you please go? Yes. So in general, endodontic is a treatment of diseases, bulb, root canal, and different supporting structures and there are many several various and there are actually with the infections, and there are several factors that determine the success of or the failure of the treatment. And as Bettencourt stated in 2017, one of these factors is the variation of the root canal anatomy, which may contribute the success or the failure of the endodontic treatment. Furthermore, Migat stated in 2019, so the knowledge of the presence of an extra canal or additional canal in the root canal system is very important. So root canal morphology must be well understood for successful endodontic treatment. So the second mesobuccal canal is actually located in the mesobuccal root. Now, can you go to the next slide, please? Yeah, so the second mesobuccal canal actually is located in the mesobuccal root, and one of the most common reasons of root canal failure is missing or undetecting the canal. So the complexity and the difficulty of the root canal anatomy was first recognized in 1925, a few decades ago, and worldwide the current prevalence of MB2 it's roughly about 18 to 95%. Can you move, please? Yes, more. So actually, in regards of the different methods, there are several studies that have been used, the various techniques to detect the MB2 canal in the maxillary molars. And one of these techniques is the conventional intraoral periapical radiograph, but that only provides two-dimensional images for a three-dimensional structures. I think you need to move a little bit faster because you will miss the, yeah. So with the growing demand and the popularity of the COMPIM CT, especially in dentistry, which was first introduced in the field of endodontic in the early 19th, and in general, COMPIM CT is a cone-shaped or pyramidal X-ray beam that provides a three-dimensional images. Mm-hmm. Sorry. Can you hear me?
Yes, we can.
We've lost you, Huda.
Huda, are you still with us?
I think there's load shedding in many places at this point in time, so that's probably the challenge we're having.
Yeah, I think she's out of the meeting, which means her connectivity has dropped. So let's give her a minute or two. She's back.
Can you see that she joined, Rajeshi?
Yes, she joined and then her connectivity dropped, which means she's having a problem. So let's give her a minute.
Rajeshi, can you just check if the chat is disabled, or are people able to put anything in the chat? I'm just...
It's not disabled, but can you Sueda Ahmed has her hand up.
Go ahead, Sueda.
Prof. Chetty, is it possible to go to the next presenter and maybe come back?
Yes, I think that might be a good idea. All right. All right, because of these technical difficulties, is Julian, are you online and ready to go next? You can begin to share your screen, Julian, then I'll know that you are ready. Are you able to unmute and let me know? Okay, Julian is from the Department of Community Dentistry at the Faculty of Dentistry at WITS. She is also a member of staff at the Department of Preventive and Community Dentistry at the Dental School at the University of Rwanda. Her topic is prevalence and factors for caries among HIV-positive and HIV-negative adults in Kigali in Rwanda. So Julian, if you are able to join us now and share your screen and perhaps do your presentation.
She's here. Can you unmute Julian?
Okay, she's unmuted. So, Julian, can you hear us? Julian, can you hear us?
I see your hand up, Yolanda. Do you want to say something?
Chat is disabled. Yolanda, you say the chat is disabled. Let's use the Q&A then.
Okay, so she's saying that she cannot unmute, but can you ask Julian to try again, because I've unmuted her from my side.
Chair,
Shinuka?
yes. What I will do is that I will send the 3 entrants a link to the panelists link. And perhaps they can maybe get off this webinar and then join in through the panelist links. I think it'll be much easier for them.
Okay, that might be a
Thank
good.
you.
Jayashree?
Hello, yes.
Oh, I can hear you. The presentation just went off. Do you want me to post it this side?
Shanuka has a copy of the presentations. So she's now sent the students a link because I think they registered on as attendees. So that's why they're having this problem.
But you can change their status, yeah.
Okay,
Will you the host, you must just right click on their name and then add her as a presenter.
Okay. So I've got, I'm with Julian and it says mute, remove permission to talk, chat, or hide non-video participant. It doesn't give me the option to add them as host.
Not as host, as presenter. Okay, let me see if I can.
Please help because I can't do it from my side. Thank you.
What's her name? Let me go look for her.
Julian.
Julian.
Yeah.
Okay, I'm looking for Julian's name.
Thank you.
Julian
Yes.
Chat promotes to panelist. Okay, now she can. She's a panelist.
Okay, thank you for that.
No problem. Now she can share her presentation.
Julian, are you able to share now?
Rajeshri, I still don't see any of the
Yes, she's
students on
still
the panelists.
she's still she's still an attendee here, so that's the problem.
There she's connecting now.
Okay, great.
I'm happy that I'm appearing so many times on the screen.
Hi everyone, can you hear me now?
Hi, Julian. Yes, we can finally hear you.
Yes,
Can you hear me?
Okay, let me
Yes, we
share.
can hear you.
Yes,
Hang on.
finally.
Huda's also back in the room.
So can you see my presentation now?
Yes.
Yes, we
It's
can.
perfect.
Okay.
Chetty, can you just explain to everybody else? Huda's there, everybody else. Can you just explain that to the second one?
There is so much echo, but let me
Okay.
start to present.
Okay.
Good afternoon, everyone, and
everyone,
thank you for this time.
Just
I'm
an
very happy to
update.
present to you this research title, Prevalence and Factors for Caries among HIV-positive and HIV-negative adults in Kigali, Rwanda. This research work was supervised by Prof. Verasamy Ngopa and Dr. Yolanda Marere Korisa. Can you hear me?
Yes, we can hear you.
Yes, this is the outline I'm going to go through. As introduction, oral health is an integral part of overall health, and it is strongly associated with systemic condition. The prevalence of dental caries is higher among HIV-positive persons than the general population. Also, dental problems among HIV-positive individuals are known to be more severe and difficult to manage compared to oral problems among HIV-negative persons. Thus, oral health care should not be ignored and should form an important component of comprehensive treatment available for HIV-positive patients. Look at Rwanda context. Oral diseases are one of the important health problems in the country, considering the high burden reported in the latest National Oral Health Survey. Nearly 65% of participants in the survey have experienced dental caries, with more than 54 untreated dental caries. No study done in Rwanda yet to look at the prevalence of dental caries and associated risk factors among HIV-positive individuals. So the aim of this study is to determine the prevalence of dental caries and associated risk factors among HIV-positive and HIV-negative adults at an HIV clinic of Kigali Teaching Hospital in Rwanda. This was a comparative cross-sectional study done among HIV-positive and HIV-negative adults, and the sample size was 400 participants, including 200 HIV-positive and 200 HIV-negative adults. Oral examination was performed by a calibrated dental therapist, and caries was assessed using DMFT index. Participants were seated in semi-supine position and examined under natural light because this study was done in an HIV clinic. A questionnaire was used to record data related to risk factors associated with dental caries among our population. Descriptive statistics, chi-square test, and multiple logistic regression analysis were considered for data analysis. And we used Stata version 15 to analyze data. So this is the presentation of the results. And as you see in this table 1, which indicates the distribution of dental caries according to HIV infection, you can see that HIV-positive participants were more affected by dental caries compared to HIV-negative participants. Here, the mean D-score and the mean DMFT score were both higher among HIV-positive people compared to HIV-negative individuals, and the difference was statistically significant, as you can see. This table 2 illustrates the factors that were associated with dental caries among HIV-positive and HIV-negative adults. Here, being a female and frequently visit dentists were predictors of dental caries among HIV-positive people, while in HIV-negative individuals, frequent dental visits and middle age range were also predictor of dental caries among HIV-negative participants. Regarding this table 3, a separate multiple logistic regression analysis was done to determine HIV-related factors that were associated with dental caries among HIV-positive respondents alone. And for this table, we adjusted for all previous factors that were not related to HIV infection. As outcome, detectable HIV viral load was a predictor of dental caries among HIV-positive participants. Here is the brief discussion of key findings. As you have seen, HIV-positive participants were more affected by dental caries compared to HIV-negative participants, and similar results were found in the literature. However, some researchers found the other way. Therefore, contextual factors should be taken into account when analyzing or considering factors from different areas. If I give an example of Rwanda, there is lack of oral health education and caries prevention services within HIV clinics throughout the country. No program to raise awareness of dental caries risk among HIV-positive people. Also, the results have shown that females were more affected by dental caries compared to male. Similar results were reported in various research, and also different factors have been reported to expose females to dental caries compared to male. For example, female family role of preparing food exposed them to snacks, cariogenic snacks, and in between meals. In addition, females go through hormonal changes and during the puberty and pregnancy time, and this can modify the salivary flow, making the oral environment prone to dental caries compared to male. Therefore, oral health intervention should consider female biology and condition when planning for program to prevent dental caries among any given population. Also, frequent dental visits were associated with dental caries among both HIV-positive and HIV-negative participants. This may be explained by the fact that DMFT is affected by previous treatment done. Like for instance, in our study, the M component, which is missing teeth due to caries, was the most prevalent component of DMFT for our participants. This suggests that the participant in our study visited the dentist at a late stage where it was not possible to save their teeth. And of course, this implies poor oral health seeking behavior, which was previously reported in sub-Saharan Africa. Detectable viral load were also associated with dental caries among HIV-positive respondents. These results may suggest the effect of dental caries on immunity or vice versa. However, further prospective studies are needed to clarify on this relationship. As our conclusion, there is a need for effective oral health intervention specific to HIV persons in Rwanda to raise awareness on the risk of dental caries and provide preventive oral health services among this population. To ensure timely oral health care among HIV-positive individuals, there is a need for effort from policymakers and other stakeholders to integrate oral health care services within HIV treatment program in the country. Also, further prospective studies are recommended to clarify on the causal relationship of dental caries with HIV viral loads. One of the limitations of this study is that the results of the study are not generalizable to the general population of the country because this study was done in an urban HIV clinic in Kigali city. In addition, a cross-sectional study design makes it difficult to establish the causality. My acknowledgement goes to Kata, my funder, my supervisors, my mentor, family and friends who supported me a lot during this research work. Thank you very much for listening.
Thank you, Julian. So this is your poster that you've put up.
Yes, this is my post.
Okay, now we will invite the floor, open the floor to any questions, any discussions. Anybody would like to ask Julian anything?
Prof. Singh has a hand up.
Oh, yes. Prof. Singh.
Sorry, Chair, this is not a question, just a message for the two speakers, if they can please jump off this link and join back on their previous link, and then the host will help them to connect. Thank you.
Okay, Huda, we haven't forgotten about you, or we just had these technical difficulties. So if you can also then just get back onto the panelist list.
Yeah, so I'll go back now.
Okay. Any questions for Julian?
May I?
Oh, sorry. Yes, yes, sure, Prof.
Okay, may I ask? Hi, Julian. Thank you for that presentation. Just a quick question. I hear you use the word generalizable quite a few times.
Prof. Khan?
Yes.
There's quite an echo.
Is there a way to mute? There
side.
is so much echo, I can't get anything. There is echo sound that is preventing me to hear.
Yeah, maybe you have two, I don't know, two devices.
The reason I don't. The reason there's an echo because there are two other people on my name. Can you hear?
Yes, I can hear now.
Okay. Let me just I'll do it slowly. You used the word generalizable a few times. Can you explain what you mean when you say generalizable and use the entire scientific sort of explanation for it? Explain why we say something is not generalizable.
I hope I have got your question, although there's so much noise. Is it that why my results are not generalizable to the general population of the country? Is it the question?
Yes. Explain what it is. What is generalizability? What does that mean? Okay.
Julian, you need to explain what is generalizability and why you used it in your study, in your presentation.
Okay.
Thank you.
Thank you so much for the question. So what I mean by generalizability is that the findings of my study, depending on my study population, can be compared or can be generalized to the entire population of the country. In my context, I use this term because my study was done in an urban area in the country. Also in one of the HIV clinic And my view is that participants in urban area can't be compared to the people from rural area, especially in the country, depending on many factors like availability of facilities, dental personnel, and other factors. So that is why I said it is not possible to compare, to generalize my result to the entire country. Maybe there is a need of further studies to be done in the rural area to compare the results. Thank you.
Does that
Thank you.
answer your question, Prof. Khan?
Thank you. Carry on.
Julian, if you don't mind, I would like to just ask, you said that your findings aligned with some studies and were contradictory to others. Which studies did they contradict? Was it like first world countries, or what sort of socioeconomic background, or which countries did you see that your studies aligned with, and which ones didn't it align with?
Thank you so much for that question. For example, my results, when you look at the higher prevalence of Caries among HIV positive, were aligned with the neighboring country, which is Uganda, in a study done among adult HIV positive participants. Also, they found that HIV positive participants were more affected, and even female were more affected. However, when I look at the study which was done in South Africa, they found that it was in adolescents, HIV negative were more affected compared to HIV positive participants. Yeah, those are the study that I have seen. And that is why I was discussing, saying that maybe the contextual factors should be analyzed when reporting factors from different areas to see why in some areas HIV positive people are more affected than in other areas. Thank you.
Okay, yes. Thank you very much, Rajeshri.
Thank you for that interesting presentation, Julian. I'm super proud of you because I'm also a dental therapist. So well done to you. And I'm happy that dental therapists are also conducting research all over Africa and even in South Africa. So thank you for that. Julian, just a little comment. You've done the DMFT within this sample and within this population. Do you have any data on the DMFT of the people in Rwanda? So can you compare this data with the entire population in the country, if this data is available?
Yes, there is data, although it was not among HIV positive participants. Like I was presenting, I showed the result from latest National Oral Health Survey, which is the only one oral health survey done in Rwanda, and it has reported higher prevalence of dental caries among Rwandan population. It was the general population, not adult like my study, but I have that reference to compare with my study also.
Okay, Dr. Motley, is that okay? Prof. Van Wyk, I see your hand is raised.
Thank you so much, and thanks, Julian, for your presentation. Very interesting. I would just like to know two things, though. The first one, you mentioned that you had a semi-structured questionnaire. Was it based on a validated questionnaire? I couldn't catch the logistics, literally what was on it. I think in one of the slides, there was a few things that was under the table to say what was part of the semi-structured questionnaire. So that's the one part. And then the other one is that you indicated that regarding the population size, there were much more women in the population. And do you not think that this could influence your result? As we all know, women tend to actually seek help more, or treatment more, or oral health education more. Thank you.
Thank you so much for your questions. The first one regarding the questionnaire I used. Normally, I used the questionnaire that I was adapted to the WHO regarding the risk factors. So I adopted the one provided by WHO regarding the risk factors for dental caries. And then regarding my participants, normal for my sample size, the female were not more than male. Only that the results have shown that female were more affected by dental caries than male, not in the sample size. Thank you.
Thank you, Julian. Are you happy with that, Prof. Van Wyk?
Yes, thank you so much.
Okay, I see Dr. Skeepers, your hand's up. Would you like to ask Julian a question?
Good afternoon. Thank you very much, Julian, for the presentation. I'd just like to ask, during your discussion, your risk factors that you mentioned, did you look at the pathophysiological changes that might occur in HIV-positive patients, like reduced salivary flow, and how that can affect increase in caries risk? Thank you.
Okay, thank you for the question. You correct me if I did not get it well. Yes, I discussed about saying that, yes, that is about the female. The female, yes, female can be exposed to saliva flow reduction during the time of pregnancy and during the time of puberty. And this can expose them to dental caries compared to male. So I was discussing about the factors, the fact that female were more affected by dental caries compared to male. And this might be one of the causes of the higher prevalence of dental caries compared to male. However, as I said in my limitation of the study, this is a cross-sectional study and it can't really establish the causality. That's why I recommended further studies to look at the relationship among some of those factors. Thank you.
I think what Dr. Skeepers was asking, and Rwanda could correct me if I'm wrong, if you look at the pathology or the pathophysiology of someone that has HIV, there's certain changes that happen, for example, in their salivary glands. And that's regardless if they're male or female. So I think what he would like to know is, did you address that point maybe?
Thank you so much. Yes, I understand he's asking about the xerostomia. And in my study, in this model, I didn't put the variable because there were people were not reporting the xerostomia effect. And also, when I was reading the literature during the examination, people may present with the xerostomia during the time you are examining due to anxiety and other things. So that is why I did not look at the xerostomia when I was examining my participants. So this factor was not discussed within this scope here. Thank you.
All right. Thank you very much. If there's no more questions, we could maybe then move on to the next participant. Prof. Khan, should we go back to Huda now?
I think so. Yes. I think she's started.
All right, Huda, if you can get ready to present, start sharing your screen and unmute yourself.
Prof. Chetty, Dr. Moodley still has to convert her mode.
Okay, we're doing that.
So we should just wait a minute or two. Okay, I see Huda on.
Stan?
Yes.
Okay, hello everyone. Thank you for the multiple chances.
You're welcome. Huda, are you ready?
Yes, can you see my screen here?
Yes.
Just go. Okay. Okay, so good afternoon, everyone. I am Huda Mohamed Abou Gheba. Today, I'm going to present the prevalence allocation of second mesobuccal canal in the maxillary first and second permanent molar using COMBEAM CT in a sample of Libyan population. In general, endodontic is the treatment of diseases about root canal and different supporting structures with infection. And there are several factors determine the success or the failure of the treatment. And as Bittencourt stated in 2017, one of these variations, one of these factors is the variation of the root canal anatomy. And also furthermore, as Megat states in 2019, the knowledge of the presence of an extra canal in the additional canal in the root canal morphology is very important. So the root canal morphology must be well understood for successful endodontic treatment. So the second mesobuccal canal is located in the mesobuccal root of molar teeth, and one of the most common reasons of root canal failure is missing or misdetecting the canal. So now the difficulty and the complexity of the root canal anatomy was first recognized in 1925, a few decades ago, and worldwide the current prevalence of the NB2 canal it's roughly about 18 to 95%. So in regarding of the different methods, there are several studies have been used, different techniques to detect the NB2 in the maxillary first and second molars. One of these techniques is the conventional intraoral periapical radiograph, but that only provides two-dimensional image for three-dimensional structure. So now with the growing demand and the popularity of the COMBEAM CT, especially in dentistry, which was introduced first in the field of the endodontic in the early 19s, and in general, COMBEAM CT is a cone-shaped or pyramidal X-ray shape that provides a three-dimensional image. So the aim of this in vivo study is to describe the prevalence allocation of the NB2 in the mesobuccal root of first and second maxillary molars, and to describe the methodology to enable its geometric location in a sample of Libyan population using COMBEAM CT. And our objects was first to determine the prevalence of the NB2 canal in different root thirds, and also to evaluate and categorize the root canal morphology of mesobuccal root, and to determine the location and the distance of the NB2 in the relation of the first mesobuccal canal and the palatal canal, as well as our secondary objective was to determine if there is any association between the location and the distance of the NB2 with the age gender of the study sample. So basically, this is a cross-sectional analytical study. It was conducted on radiograph images and were in the patient's records and were taken for general diagnosis and treatment for the patient record was obtained from 4 different dental and radiology centers in Libya, which served the broader population of indigenous and foreign residents. So how we did this study? So first of all, we opened all the values on a multiplanar reformating window, and the axial slice was conducted, and then the coronal and the sagittal slices was oriented parallel to the long axis of the root to detect the exact location of the MB1 and the palatal canal. And then the root were divided into equal thirds and after that we checked the presence of the MB2 in each root, 1 millimeter, 3 millimeter, and 5 millimeter apically of the floor of the pulp of the mole being evaluated. And actually these roots or these thirds referenced as a coronal third, middle third, and apical third. And all of these observation and measurement was done and followed according to the protocol have been described by Aparsa in 2015. And the geometric location of the MB2 was detected in relation of the MB1 and the palatal canal, so that by detecting first of all the location of the point, the central point, and after that we drawing a line that connecting the 2 points, MB1 and the palatal canal. Then we visualize the presence of the MB2 either mesially or distally of this line, and after that we locate the central point of the MB2 and drawing a line that projecting and connected between the MB2 and MB1 canal. So the third line here, it's projected perpendicular to the MB1 and the palatal canal, and this point we reference it as point T. So all the measurement as well were done according to the protocol described by Pittencourt in 2016, and the distance between the points were measured in millimeter. So for the root morphology evaluation, the observation were made as a Virtutious classification. And so the data were analyzed using descriptive statistic, and the association between the MB2 canal, gender, and site were determined and established using a Pearson chi-square test. And for the relation to the age was used the t-test, while for the inter-rater reliability was assessed using the CABA test to determine the prevalence of the MB2 and the Blom-Altman test to determine the accuracy of the distance. So here we go with our results. So a total of 66 individuals complied with the inclusion criteria consisting of 175 teeth. And the overall prevalence actually for the MB2 were 48%, and the distribution for the first maxillary molar were 46.9%, and the second maxillary molar showed a lower incidence of MB2 with 39.4%. So our results for the first maxillary molar were inconsistent with the study have been done by Zhang in a Chinese population, and also 3 studies carried out in a Brazilian population. But we conducted with a study on a South African population, which reported that the highest frequency of 89%, and this was also noted in a Korean population with the 71% and in Kuwaiti population with 79%. While the investigation of the second maxillary molar, so our results match these observed in the Chilean population and as well as in a Korean population, and there is a slight contrast was noted with the Brazilian population. Regarding of the morphology, so all types of Virtutious classification were found in this present study except type 1 and type 6. So these results are inconsistent with the other similar studies in the United States and Brazilian population, which is show that the most prevalent type of the MB2, it was type 2, and was confirmed with a study in Iraq that reported the most prevalent type was type 2 as well. And our result was in contrast with a study was done on Egyptian population that reported the highest prevalence were for type 1 and type 4. So in regarding of the distance, our study, so in this study, MB2 was detected nasally to the MB1, and the distance of the first maxillary molar was 2.4 millimeter palatally and 1.5 millimeter mesially of the MB1 canal, while for the second maxillary molar, the distance was 2.5 millimeter palatally and 1.4 millimeter mesially of the MB1 canal. So with the same technique, our results were inconsistent with that have been used by Pittencourt, and basically the differences were largely dependent on the method of measuring. So for example here, Gordusis used the dental operating microscopy to study the location and the pathway of the MB2 in the first and second maxillary molar, and reporting the average distance as within 3.5 millimeter palatally and 2 millimeter mesially of the from the MB1 canal. So regarding gender, no significant differences were noted in the prevalence of the MB2. So in summary, a clinician and the practitioner should be or not need to be aware of the anatomical complexity, so the clinical application and the importance of our result could be applied to the learning and treatment outcome of the root canal therapy. And these morphological variations explain why certain canals could be left untreated and that lead to treatment failure. So as well as a clinician should not use combeam CT imaging routinely unless indicated due to the high radiation exposure. So in conclusion, the main goal for this current study was to determine the prevalence and location of MB2 in the selected sample of Philippine population. So our results revealed that 48 of the MB2 was present, and also indicated that the combeam CT is an accurate and effective diagnostic tool, not only for detecting the presence of the MB2, but also to determine the location of the canal in vivo in the mesobuccal root of maxillary molars. And thank you so much.
Thank you, Huda. If you can now put up your poster.
Okay. Can you see the poster?
Yes, we can. All right. Does anyone have any questions for Huda? Any comments that you'd like to make? Dr. Modley?
Thank you. Thank you, Huda, for that interesting presentation. I'm going to ask a question, but I don't know whether it's an appropriate one, but root canal treatment and root canal anatomy is not part of what I do. So I'd like to know, your selection of teeth was between the age group of 17 and 65. So it's a huge range. So does that affect the MB2 canal? Would you see it in a younger patient or an older patient? Would that affect your results in any way?
Thank you for your question. Actually, according to our result, it was no significant differences in the age, gender, and the side of the canal. So no, this is the answer for the question for this study. No, didn't affect.
Okay, thank you for that.
My pleasure.
Dr. Skeppers?
Good afternoon. Thank you very much for your presentation. So I just wanted to ask, what inclusion and exclusion criteria did you have for participants in the study? Thank you.
Thank you so much for your question. Actually, our inclusion criteria, first of all, the age, it's between 17 to 65 years old age at the time of the scan. And also the maxillary and the maxillary first and second molars had to be present, as well as it should be fully erupted, and the root must be completely development. So this is for the inclusion criteria. Also, for the CBCT images must be the quality of the image very high resolution. And for the exclusion criteria, actually we exclude any maxillary molar that had any restoration or metallic restoration or endodontic treatment, previous endodontic treatment, or any history of trauma, surgery, as well as pathology. And also we exclude any abnormalities of the pulp chamber itself. So maybe, for example, like bulb stones or internal root resorption. Thank you.
Thank you very much.
Dr. Enderman?
Hi, Huda. Thanks for your presentation. Just a question, what field of view did you use when you were examining your studies? And did this have any effect on your results?
So actually, we're using a small field of view, because if we reduce the field of view in this study, especially in this study, the required effective radiation dose will be lower. So furthermore, the other advantages of a small view of field of view that decrease the time to process and also read the image with the better ability to avoid metallic structures that could interfere with the quality of the image.
Thank you. Thanks.
Okay, I'd like to ask you a question, if you don't mind, Huda.
Okay.
So you know that we don't routine or in our resource challenged environments, we don't always have CBCTs.
Yes, sure, yeah.
So we can't take a CBCT routinely for every root canal treatment because it's just not available or logistically impossible. So what are some of the indications or the conditions that you would now say, listen, I need to motivate to have the patient have a CBCT, so refer the patient maybe for the CBCT?
Yeah, so thank you, Prof. Shetty, for the question. And actually, first of all, we just following the guidelines as set by Sedentech CT state that limited volume, high resolution CBCT may be indicated for only a selected cases in endodontic. So actually, this is depending on the clinical trial. Like for example, the endodontics or the general practitioner, if he had the right protocol with the endodontic treatment, and the patient come back with pain or with the failure of the endodontic treatment, so maybe this is the point come out and maybe suggested there is a complexity of the root canal treatment. So actually, there is another guidelines according to the American Academy and Oral Maxillofacial Association that states there is a guidelines for the using of the COMPIM CT, and one of these it's the complexity of the root canal treatment. So yes, so we can't use the COMPIM CT as a routinely in the clinic, but as I mentioned before, that this is depending on the clinical trial. Thank you.
May I? Prof. Chitty?
Prof. Khan, yes, of course.
Thank you, Huda. Thank you for the presentation. Just one question latch on to what Prof. Chitty asked you. So CBCT is not
Can't hear properly, Prof. Khan.
Okay, sorry. Can I speak? I'll speak closer. Can you hear now?
Professor Khan, there's an echo on your sound.
Okay, maybe I mustn't ask questions. Carry on, Prof. You ask.
No, Prof. Khan, is there another device that's open?
No, nothing. Nothing's open by me. Remember you had someone on my name. Did it change?
Yes, no, all of that has been removed.
I have no idea why. Okay, Huda, just